Hello, I will talk now about another project in DRC, in the beautiful region of Ituri on the shore of the Albert Lake, where malaria is a big issue and where we combine a medical approach targeting the human reservoir of malaria and a vector control approach. The Angumu health zone is divided in 22 health areas, but only 14 are safely accessible for us on the eastern side of the river Kakoi. MSF is present in the zone since 2019 after local conflict and population displacement. We support 9 health areas as well as the zone hospital. The population is approximately 200,000 people, that includes 65,000 IDP. The malaria profile is considered as holoendemic and perennial. That means the highest malaria profile possible, and it's all year long. A mortality survey in January 2020 indicated us that the mortality rate were above the emergency threshold, and malaria was the main cause of mortality, and it was triggering our response. Then, to respond to this situation, MSF did 3 rounds of mass drug administration in the highest malaria incidence area. Then, the MOH and MSF distributed mosquito nets to the population, and we also did an IRS campaign in 2 health areas. As we can see in the graph of our routine data, but also in the table from the mortality survey, the 3 rounds of MDA clearly had an impact, especially on children. However, the long-term impact of it was questioned, when, on the other hand, the net distribution and the IRS seem to have a longer impact, but maybe less powerful. Hence, we propose to do an operational research to evaluate the impact of combining IRS and MDA. We divided the zone in 3, in the south, where there is highest incidence to receive MDA and IRS, and in the north, which is the farthest from the zone hospital, we propose to do IRS only. Here is the chronogram detailing our methodology. It was based on 2 cycles of MDA-IRS activities. The first started in July 2022 and the second cycle in January 2023. The monitoring and evaluation was done through different retrospective mortality survey and cross-sectional survey to assess the malaria prevalence. We also added an entomological monitoring with a program of mosquito capture to monitor the density and also to do molecular analysis to investigate their infectiveness. The implementation results were excellent, with MDA coverage over 86% at the lowest, and an IRS coverage reaching 97%. That represents almost 25,000 households sprayed every round. The results on the mosquito density in the graph below were pretty impressive also in both zones, and even possibly impacting the mosquito density in the central control zone. On this graph that represents the malaria prevalence survey results, we can see that even more than 1 year after the last cycle of activity, the prevalence remains low in the MDA IRS zone. This is the blue line. While in the IRS zone, in orange, the zone returned to its original level of prevalence. The control zone in green declined after September 2023 due to IRS and MDA, but separately performed in this area. In conclusion, we suspect a combined and long-term effect of MDA associating with IRS, targeting the human reservoir and the vector control. And we are currently analyzing our mosquito sample to determine the entomological inoculation rate. It's an indicator that will reflect the transmission of malaria, and that will help us to support the statement of this possible combined effect. However, what we can already say that all of these efforts were successful, because since 2 years now, the children mortality finally decreased under the emergency threshold. I thank you for your attention, and please don't hesitate if you have any question.